Welcome to video 10 of the Safe Recovery Program training program. This video is Gathering Information Part B. I'm Terry Haines. The objective of this video is to understand the purpose of collecting information about mobility approach and threat appraisal, and to learn techniques to establish an open response to questions in these areas. As I've mentioned in the previous video, the Safe Recovery Training Program is structured around an information gathering section and an information provision and joint problem solving section. And in this video we'll be covering the last two sections of the information gathering, the mobility approach and threat appraisal. So, starting with mobility approach. It's very important to be able to understand how patients perceive their mobility. Asking the question, do you feel unsteady on your feet at the moment, may elicit a response which comes across as a denial of a problem. Rarely do people want to admit to unsteadiness, but they will admit to their walking not being the same as normal. This is why in the self-learning activity, I asked you to ask the patient whether their walking felt different to how they normally walk. So using this different approach to asking about their mobility is what I found to be the best way to get an open and honest discussion on this topic going. And if they're willing to admit that their walking is not quite as good as what it normally is, follow up and ask how. You can focus on how much their walking has changed since they were first admitted to hospital also. So to get an understanding of how far in the recovery process the patient thinks they've progressed to this point in time. In my experience, male patients tend to be less forthcoming in discussing issues with their mobility problems. It's important to understand how patients perform mobility tasks at present. So using the question, if you wanted to walk around your bed at the moment, tell me, how would you do it? If you wanted to go to the toilet at the moment, tell me, what would you do? When you ask questions like this, don't prompt them on asking for assistance using a call bell. See if they volunteer this information naturally. You can prompt them though at the end of their description about whether and how they would ask for help. The final section on information gathering is information about threat appraisal. Threat appraisal, again, is critical to the uptake of falls prevention strategies, regardless of which strategy it may be. If the patient thinks they're at risk of falling, usually this threat is based on the perceived threat from self-experience. This could be their own falls or falls that others have had that they've witnessed or heard about. I remind you of the hierarchy of threat appraisal, whether people perceive the threat in hospitals in general, whether people perceive the threat is there for people like them, and then whether people perceive the risk for them personally. If the answer to these questions changes as you move across from general falls risk on the left to individual specific falls risk on the right, you need to ask the patient why. Why do you think that falls happen in hospital but not for patients like you? Or why do you think falls happen for people like you but they won't happen for you personally? And find out what reasoning patients provide as for this discrepancy. Do bear in mind the perceived falls risk is task specific. This is informed by an individual's awareness of their own physical limitations, which takes us back to framework number 1. It's informed by perceived demands of the task. And really the question that needs to be posed by a patient is, do I have the ability to perform this particular task, or in this example, to walk to the toilet? When perceived ability is equal with the perceived demand, then the patient is likely to try and attempt the task. However, if the perceived ability is an overestimate of the true amount of ability, and there is a degree of misperceived ability, an overestimate of what people can do, then the patient's going to be putting themselves into a very dangerous situation. They're going to be taking a malinformed risk. Patients may have poor awareness of the mobility limitations or the implications of this. For example, they may realize that they are unsteady, but not that they therefore need help to walk around the bedside. And this relates to emergent awareness and anticipatory awareness and intellectual awareness, as discussed in video 3. The perceived risk of falling, again, varies according to the difficulty of the task being considered. Patients think they're more likely to fall going to the toilet than around the bedside. In fact, 68% of patients think falls most often occur in the bathroom and toilet area compared to any other area. And again, this research has been published and is openly accessible in the journal Open Longevity Science. Are they right or are they wrong? Well, they're right on one hand. Risk, all other things being equal, is likely to be higher with the more difficult activity, and in the bathroom, having to walk further away from the bedside and the potentially wet environment that they might encounter there might be a more difficult activity. But they're also wrong, because all other things are not equal. If the patient is less likely to ask for help, then all other things are not equal. If they have risk compensation, that is, they may be less likely to ask for help with the activity they perceive is less risky by the bedside, then again, all other things are not equal. Remember, more than 50% of falls happen by the bedside. Indeed, approximately 2/3, whenever I've reviewed falls incident reports, of falls have happened in the bedside environment on a hospital ward. Some final comments on information gathering. Try to leave collecting information on the falls history and threat appraisal until the end of your information gathering with the patient. This is because some patients do not like to talk about falls. Talking about mobility approach naturally leads into the discussion about falls. So if you can do the mobility approach section first before talking about falls, you'll usually get a more natural progression in your conversation with the patient. Some patients, again, would also benefit from really having that opportunity to talk about their problems and issues that they're experiencing on the ward, developing a relationship with you and some trust in you before discussing a topic that they might feel is quite intimate to them. The section on information gathering does become faster with practice. In the trial in Brisbane and Western Australia, published in Archives of Internal Medicine, we timed how long it took to provide each patient with the Safe Recovery program, and it was just under half an hour. In the Western Australia trial, it was around 40 minutes. What I would advise you to do, though, is never replace rapport for speed. Rapport is essential for the success of this program. You need to develop a relationship with the patient for the program to be successful. They need to believe that you are on their side, that you are there for them, that you are there to help them, and that you are doing everything in your power to help them have a safe recovery.